All right, welcome back, everybody. Welcome to Uromigos Live 2023, Day 2. Except for the live stream hacking, Day 1 was an amazing success, so thanks to all of you for your participation. Hope you all had a good time at happy hour and at your dinners last night. And so we're kicking off this morning with prostate cancer, as you could probably tell by the panel. First of all, thanks again to our sponsors. Again, we've had amazing support both last year and this year. We're super appreciative. Obviously, this meeting doesn't happen without you all, so thank you, thank you, thank you again. All right, so here's today's agenda. So morning is basically prostate. There's two parts to prostate. First half hour or so is PARP, and then the second 45 minutes, which will be a podcast, is radioligand therapy. We'll take a short break for a set change, if you will, and then we'll have the second semifinal, which features my team, Team Cleveland, actually Shilpa's team, the team I'm on, against Team New York City. It should be a spirited battle. And then we're going to do a Rising Star session before lunch. And actually, for the mentees and for the mentors who paired with them, come up after the Uromigos Cup up here, and we'll explain to you a little bit how it's going to work. But basically, each of the 5 Rising Stars is going to briefly present a trial concept. Faculty moderator is going to help sort of moderate a discussion around it and ask questions about all sorts of things, and then we'll sort of open it up to the room, and we'll repeat that 5 times for 8 or so minutes each. Then there's lunch, which I think is in the lobby, if I'm correct, and then we'll do kidney cancer in the afternoon. We're doing a little bit backwards because Mike Atkins is flying and he doesn't land till 2, so IO refractory kidney cancer first, and then we'll do a live stream of frontline kidney cancer, and then we'll cap it all off with the final round, and there's trophies and prizes and medals, and it'll be amazing. So that's today. All right, so let's kick it off with prostate cancer. Thank you all for joining. First of all, thanks, just to back up, thanks to all the faculty. We know this is a super busy time, right, with ESMO and PCF and alliance meetings and all that, so we do appreciate you taking your time to be here. So I'm going to let the prostate panel introduce themselves, and Michael, we'll start with you.
Great. I'm Michael Morris. I'm the prostate cancer section head at Memorial Sloan Kettering Cancer Center.
Rana McKay, GU medical oncologist at the University of California, San Diego.
Tanya Dorff, the section chief for genitourinary cancer at City of Hope.
Neeraj Agarwal, GU medical oncologist at the Huntsman Cancer Institute, Salt Lake City.
Awesome. All-star panel. All right, so again, first half hour is on PARP inhibitors. There's been a lot of activity over the last year in PARPs and trials and ODACs, and we've done a ton of podcasts on it, so we thought it was sort of timely to dig in. I also have to thank Michael, who helped us create all these slides, so special shout. If you don't like them, it's his fault. All right, we're going to start with a couple cases. As you know, we put out some Twitter polls in the last, week or so, just to kind of get a feel and sort of to have discussion points. So this is a 65-year-old hormone-sensitive disease who got ADT, abidocetaxel, so got triplet therapy for whatever reason, and then ultimately developed, had a rising PSA, a new bone and adrenal mets, had a PSMA PET scan, which was positive, SUV max of 9, so was diagnosed with metastatic CRPC, is asymptomatic, gets genomic profiling, and has a BCR1 alteration, and the question was, what would you offer next? And you can see 75% of respondents answered PARP inhibitors with a little smattering of anything else. Neeraj, we'll start at the end there. Anything you would add to this? Why not PARP plus not NHT?
Yeah. So if the patient had discontinued abiraterone for any reason, for example, we are looking at patients who have locally advanced prostate cancer and they get abiraterone for 2 years. And if this patient had discontinued abiraterone without progressing on abiraterone, I think there could have been a rationale for using enzalutamide plus talazoparib in this patient. But if patient is already progressing on an NHT, we do have profound trial data for those patients, single agent PARP inhibitor. So I think that would be my rationale.
And does the type of alteration matter because it's BRCA1 and so sensitive, or not really, in terms of single versus dual therapy?
It doesn't matter from the single versus dual therapy, but it matters from the perspective of what kind of mutation is that. So I will be more enthusiastic about BRCA1, BRCA2, based on recent data, CDK12, and many other mutations. But there are some mutations we know may not respond very well. So.
Okay. Tanya, anything to add? Or?
Yeah, I would just say we've learned that for patients with BRCA alterations, it's so important to use this very effective PARP inhibitor as early as possible and prior maybe to something like chemotherapy.
Yeah.
Or even lutetium, I would say, because it's just such a strong biomarker.
Agreed. Rana, anything else?
Yeah, I actually think I would be thinking about doing talazoparib with enzalutamide in this context? The patient was on abiraterone for over 2
Wait a minute,
years.
you want to give Enza and Neeraj doesn't?
You know, I have to say,
Are your chairs reversed?
this is a BRCA mutated patient. They're coming off, you know, they had Abby for over 2 years. Yes, it's in the MHSBC setting, but we know these patients do so poorly, and this is where the frontline PARP data, frontline MCRPC data kind of shines. Now, granted, there was only 50 patients from TALAPRO-2 that had received a prior ARSI, but this is one of those situations where I would have that discussion with the patient. And they're an Abby to Enza as opposed to an Enza to Abby, so I'd have that conversation.
Okay, fair enough. Michael?
Yeah, it's hard to add anything to the insightful comments from before. We just don't know whether the PARP alone versus, in this context, combination therapy is one superior to the other. Why wouldn't you do some of the other choices? Well, cabazitaxel, like Rana just said, PARPs probably should be given earlier rather than later. Enzalutamide, Abby to Enza, like she just said, really nominal activity. The lutetium kind of tricky because the question, and Neeraj developed the question, so I'm presuming he put SUV max of 9 for a reason there, which is right on the threshold of what we would say the sweet spot is for at least SUV mean. But we can get into that in the RLT session, but I agree, this patient has an actionable mutation. Put him on the therapy that is going to leverage that. We don't check the mutational status of the patients for you to ignore that information, but acting on that information early is better than acting on that information late, which is why I think
Or
the
not making
overwhelming-
it to that therapy.
Exactly,
right, which is
exactly.
possible,
Then you've lost a real opportunity.
Okay. All right, let's do one more quick case. I want to get to the data. So this is hormone-sensitive patients, got ADT Enza, but then actually stopped the Enza after, I think, a couple of years, 3 years maybe, because of fatigue. And then later on, again, rising PSA and new bone mets. So metastatic CRPC was on Enza, but not recently exposed. And Neeraj, I think this is sort of what you were alluding to, asymptomatic with a CDK12 mutation. So you can see this was a lot more varied in terms of response. So Abby Enza monotherapy, or olaparib Abby. I mean, you can see there's almost equal, at least for the top 3. Niraparib didn't do so well. So we'll go reverse. Michael, what would you say to these responses or these options?
Well, again, I think the same rationale on acting on the HRD mutations. So the CDK12 would be encompassed by the Tala-Enza label, which is for all HRD as opposed to specifically for BRCA. And so of the choices here, that would probably be my choice. Although it looks like I would be in the minority on that one from the audience participation. So that's what I would put my vote on.
Okay. Rana?
No, I would agree. The CDK12 is on label with the Tala-Enza. And the patient didn't really progress on Enza. They just stopped for tox, and then 2 years later are now having PSA progression. And
I see shaking heads at the end. Assume agreed. Anything to add? Neeraj?
Yeah, I mean, majority are going with the PARP inhibitor in this case, which is correct. The only thing is, as Rana, you said, abiraterone olaparib label doesn't include CDK12 mutation. And just to add to my previous comment, I didn't rule out enzalutamide talazoparib in my previous conversation. I keep it simple.
It wasn't a criticism.
Yeah, no, I'm just making it a little lighter. So anytime I see a patient who's a candidate for enzalutamide and has HRR mutation in MCRPC, I'd offer them Enza with Tala.
Okay, fair enough.
The only thing
Michael?
that I would say is we've all given the doctor's answer. But this patient stopped Enza, and now we've all said, you know what, restart it. And that may not make the patient happy, although it would be within the label of the drug, and it's probably the only on-label indication here. So I guess what I would ask Neeraj is how he would feel about giving the patient Daro instead of Enza, which he's already declared a misery factor of, and give him a less fatiguing ARSI.
Yeah, I think it's one of the choices out there. We do not have the data of combination of darolutamide with the PARP inhibitors, so that is not available right now.
I'm asking if you'd think out of the envelope there.
Sorry?
I'm asking if you would put yourself outside of the envelope.
Yeah.
Let's assume you can do it, right? There's not reimbursement
Yeah.
issues. Let's just take all that away for,
Yeah.
for discussion.
I'll definitely consider.
Yeah.
Absolutely. In this case, this is a real case. And many patients with metastatic hormone-sensitive prostate cancer, after being on ADT intensification therapy, they are stopping, especially with undetectable PSA rates. They want to take a break from the chronic side effects. Doesn't mean they are completely intolerable. I'm sure we all have those cases who want to just take a break just because they have been on this deeper androgen blockade for like 3 years, 4 years. And I think it's reasonable to start these patients back on a NHT when the disease progresses.
I think to piggyback on what Michael was saying about the darolutamide, we're compromising the dose of the talazoparib with the tala-enza combination because of the fact that enza is having an effect on the PARP, and we really don't know what is the optimal tala dose with DARA, so I would probably not do that, but would think about strategies to mitigate the fatigue, exercise programs, stimulants, dose reduction, potentially on the enza if needed. So I think there could be things that could potentially be done, but I love the point that we need to factor in what the patient is experiencing.
But not PARP monotherapy.
Well, along those lines, why is
You
PARP
could, but that's
monotherapy
not
there?
listed
Ask
on
Neeraj,
the.
he made the question.
No, I mean, I wonder if it's because CDK12 didn't seem like such a strong predictor in the olaparib monotherapy setting, and do we think there's a difference when you use the PARP in combination with the AR pathway inhibitor in terms of which HRR alterations become really predictive for benefit?
And I do think the combination matters rather than sequencing. Combination does have some appeal to me for multiple reasons.
Okay, we're going to get there.
Yeah.
All right, so we're going to spend our last time really talking about the data from the trials on this slide. We've been alluding to them. You see PROpel, the olaparib, or Abi plus minus olaparib on the upper left. Magnitude with niraparib, this was the one that was stratified by biomarker positive or biomarker negative. And you can see the panel, if you can read that, that was defined as biomarker in that particular study. And then TALAPRO-2, which Neeraj presented relatively recently, which was enza plus minus talazoparib. Right, so similar trials, but clearly some design issues that I think we're going to get into, right? So not identical and not obviously different drugs, but this is sort of the landscape. And then this is a slide that I think was adapted from Neeraj, whether he knows it or not, and then Michael and I have sort of adapted this. And this is really all.
Sorry, we changed some stuff.
We did change some stuff, yeah. Yeah, this is the first time Neeraj has seen the slide. So obviously these are the 3 trials in the columns, and then a little bit of eligibility in the first 2 rows. How HRR was analyzed, I want to talk about that first. Primary endpoint was RPFS by various review in all these trials. The next several rows are the various hazard ratios in the all-comers and then the various subpopulations as defined, response rates, survival, and then obviously just the regulatory status where it stands at the end. So let's talk first about how you determine mutation status in a patient, right? Because PROpel used ctDNA or tissue, right? And it was retrospective, and that was a huge problem at ODAC that we'll talk about. And the others were tissue and prospective. So Neeraj, maybe we'll start with you, and you can comment on TALAPRO or anything. What's the optimal method? Some required both, right? And so what do you do in practice, but then also what do you think is relevant from a clinical trial design standpoint?
Right. Just to take a step back, when we were doing the PROfound trial, almost 1/3 patients were not eligible even for basic screening because they did not have adequate quality or quantity of tissue left by the time they were being screened for the PROfound trial. And that was for our recollection post-NHT setting when olaparib was being considered for that. So having learned from that experience, every time I see a patient for the first time, I order germline testing, tissue testing, and the ctDNA testing as a part of their initial workup. I don't even wait for disease to progress. So that's my practice.
And you're largely doing that on their primary tissue, presumably prostatectomy or biopsy?
Yes.
Okay.
First time when I see the patient.
First time. And are you biopsying a metastatic site at all?
Unless
if
there has-
available, right? If accessible, I should say.
Yes, if biopsy site is available, we are always
Sure.
doing the sequencing, in addition to the primary tissue.
Sure.
Yeah.
Okay. And Tanya, what do you think? What are you doing in practice? What do you think about how these trials did it a little bit differently? Is one better than the other? Do you rely on ctDNA if you don't have tissue, et cetera?
Yeah, I think it was really important that patients were allowed to enroll on the basis of ctDNA results because we don't always have tissue. Of course, we want to biopsy a MET if possible to see what's happening in the patient's cancer at this moment. But it's really important also if they've had negative testing in the past that ctDNA can pick up a new alteration that's occurred in the course of the patient's exposure to various therapies. We know that cancers can accumulate new mutations. But you also have to be careful of negative ctDNA results if there's not a high burden of disease. So I wouldn't necessarily do it in anyone who walks in. If their PSA is relatively low, their cancer's relatively well controlled, that's not the optimal time to be getting ctDNA testing. So I think serial testing is indicated, and trying to look at what's happening in a patient after they've been exposed to 1 or 2 lines of therapy is important.
And how often, for patients who don't have tissue available, I don't know if these numbers are out there, how often does ctDNA give you an answer? You know, is it 20% of the time for, I know it's dependent on disease burden, but just rough numbers. Like how often is it useful? How often when you send it do you get a result?
I mean, I think it's not that far off of tissue in terms of if you send it when there's enough tumor burden, you will find the mutation.
Okay. Rana, what do you think about type of testing before we go into data?
Yeah, I mean, I think tissue is always preferred, and tissue that is most proximal to the time that you are making the decision is most preferred. So we know that DNA repair alterations, many of them are acquired alterations that can develop over time. But I think the clinical reality is that not every single patient who walks in the door is going to have viable tissue, is going to have an area that could be biopsied, where I think we need to integrate ctDNA as well. But I agree with Tanya that the timing of when to do ctDNA testing matters, because burden of disease matters. Just because somebody has a negative test doesn't mean they may be negative. Maybe they're in a state of disease control. So I think it's something that we need to be able to fill that gap clinically. I think ctDNA does do that, but not, probably to the level that we want it to.
Does anybody biopsy bone? Is that ever useful?
Yes.
Yeah.
And I think moving towards practices and partnerships with pathology where you actually develop protocols where this bone biopsy is being done for genetic sequencing purposes, and it's processed in a different way. But you need to set up those collaborations to allow that to happen.
Yeah, agreed. Michael, what else?
A couple of things. So first of all, the best test to test for the patient's mutational status is the one that is ordered. Because we see so many patients come in who have nothing.
Yeah.
And we're the first ones to even discuss this. Second, I think we do check both germline and somatic DNA, and we do tissue testing. And I would say for those folks who are, have the programming and muscle memory of saying biopsying bone is hard, that was in the day and age of conventional imaging. Almost everybody will be getting a PSMA PET with progression. It's an on-label study. So a PET-directed biopsy is a lot more useful and has a better yield than a bone scan, bone disease biopsy. The second, I think that it's important to emphasize that the somatic DNA is a dynamic parameter and is actionable at any point that it reveals an HRD mutation. So I'm not saying necessarily serial biopsy in the community practice, but I would say that reassessing somatic DNA at various points in the patient's treated history is important to make sure you're not missing an actionable opportunity.
Okay. So let's move on to the RPFS data. First of all, is RPFS a reasonable endpoint for these trials? Anybody want to argue that it's not?
Well, this is a tricky and highly controversial thing that some close friends no longer speak to each other as a result of.
Don't name names,
so,
just whisper them to me.
So, after the presentation of PROpel, this issue is really hotly discussed in bars and restaurants, and then has resulted in a whole series of pretty thoughtful but opposite editorials.
Yep.
So RPFS has good qualification as associated with OS in a number of clinical contexts and for a number of different therapies. In particular, the data are robust for the ARSIs. You have thousands of patients validating that rPFS reflects OS with a hazard ratio, with a correlation coefficient depending on the study of either 0.5 or 0.7, depending on the test that you use. However, in this series of trials, it was particularly controversial because the trials hit their primary endpoint for the general population of rPFS without necessarily hitting it for OS. And some have brought up that the correlation between rPFS and OS hasn't been well established in the PARP studies. And so we shouldn't presume that rPFS is a good intermediate endpoint for OS, and hence a lot of debate as to what the approval status was for the general treatment intent to treat population on these, and a focus on subsets of patients that appeared to be particularly beneficial in terms of receiving treatment.
It's a very diplomatic answer.
Very
It's really, really very diplomatic.
I expect nothing less from Michael. I mean, I think some of the issues with these trials, they were designed with rPFS as their primary endpoint, but these studies were not designed in a silo. They were designed in discussion and collaboration with the agency. And I think that, you know, if rPFS was gonna be a no-go for an approval, they should have just been designed with an OS endpoint up front. So I think midway through this whole story, we're changing the goalpost and saying, oh, you hit your primary endpoint, there's a trend for OS, the trial was not powered to have an OS signal, and now we've moved the goalpost. So that's my problem around sort of this whole area is like, well, if it was gonna be a no-go from the beginning, why not just design the trial with OS as the primary endpoint, power it sufficiently, and you know, I just feel like we kind of moved the goalpost in the middle of the game.
Yeah, and it happens in drug development, right? Because
Yeah.
times change and trials take 10 years and discussions with the agency happen, and they're never going to say it's absolutely this or that, right? It says it could be a review issue, right? It's sort of code for don't do it, right? but companies make decisions about drug development that are practical and, you know, et cetera, and you can power it for OS, but suddenly that costs a lot more money, right? So that's
Yeah.
different, right? So as you well know, there's a lot of considerations. So.
And it impacts a lot of other trials being designed in this space of different drugs that have this as their primary endpoint. I mean, what happened with these studies is going to impact a lot of other studies in the MCRPC setting that were designed with a primary endpoint of rPFS.
Yeah. Tanya, do you have something to say?
Yeah, I think although OS is the gold standard and we often want to hold our trials to that, it is helpful to take into account some of the patient-specific sort of endpoints like quality of life when we're gauging what is the benefit of this therapy, time to deterioration and quality of life, the objective response rate. And I think there's other things we can use to contextualize the rPFS benefit.
And Neeraj, is part of the rPFS benefit a function of the hazard ratio, meaning when the hazard ratio is 0.2 for the BRCA positive for rPFS, we're like, oh, of course, it's amazing. When it's 0.76 and the upper bound of the hazard ratio is 0.97, we're like, I'm not sure there's benefit there. Is that, I mean, it's a matter of degree, right?
Yeah,
it's not the endpoint's good or bad, right? But it has to be a little more impressive, a little lower hazard ratio for this kind of endpoint, I guess is what I'm getting at.
So first of all, rPFS is meaningful to me. There's no doubt. As Tanya said, delaying deterioration of quality of life, delaying the use of chemotherapy. Most patients do not like chemotherapy. Or delaying symptoms. They do matter to the patients. And combination, I think, always works. Intensification works better than sequencing, at least in prostate cancer. So from all those perspectives, I think rPFS remains a solid, meaningful endpoint to me.
So we're rapidly running out of time. Let's move on to, Neeraj, I want to challenge you to tell us why would there be additivity or synergism between NHT and PARP inhibitors? And then I might ask Michael to take the opposite view. I didn't tell him about this, but
Yeah.
I'm not sure. So as somebody,
Yeah.
I hear it and I see the diagrams. I'm like, I don't know. It seems like a lot of hand waving, and there's some references fine, but it doesn't. I don't know. I'm not sure I'm a believer. I guess convince me that there's true synergy.
So let's first discuss why should we combine them? Why should we just sequence them? We do have the data from the real world, Flatiron database, 2 papers now showing 50% attrition from first line to second line to third line therapy. And that is not unique to prostate cancer.
Right.
that is present pretty much all cancers, that only certain number of patients receive second therapy. So just by consolidating, we allow more patients to get 2 therapies. And that is one reason, in my view, why intensification works in prostate cancer, whether it is HSPC setting or MCRPC setting. But going beyond that, if you just look at the, there are preclinical data. I don't really want to go through all those preclinical rationale that when prostate cancer cells are targeted by AR inhibitors, there is upregulation of PARP, and if you inhibit PARP, that leads to AR downregulation. Simply speaking. But beyond that, if you just look at the PFS of radiographic PFS time in the TALA-PRO2 trial, if you look at the control arm PFS, that is close to PSA progression. Let's talk about PSA progression, 11 months compared to 28 months in the experimental arm. That's a 17-month difference in the PSA progression. If you just take a step back and say we are going to just sequence enzalutamide followed by olaparib, again, across the trial comparison, PROfound trial is a very different trial, but that was post-NHT. If you look at the PSA progression time or radiographic progression time with olaparib, even in BRCA1, BRCA2 patients, and if you just add those 2 times, they will not add to the radiographic PFS we have seen in the TALA-PRO2 trial in the experimental arm. So again, across the trial comparisons.
Hard to do that. I hear what you're saying. Hard to do that. But Michael, do you want to rebut that?
Well, a good cartoon always helps IRB approval in getting your trial through because it makes for a picture and saves the reviewer time to really understand the science. But I would say that you haven't shown synergy in these trials. You've shown that 2 active drugs in a patient for whom, remember this first line CRPC, right? So 2 active drugs has more durable disease control than 1 active drug. And I would say that could be independent of any interaction between AR suppression and DNA repair. And we don't really know, and I don't think that these trials show true synergy, but I do think that it shows that combination therapy, or as Neeraj said, treatment intensification. But treatment intensification does not speak to biologic mechanism. It means that more treatment exerts more disease control.
Right. So go ahead,
I want to
Rina.
add, I don't think we have fully understood the biomarker here. I think we're only beginning to scratch the surface. I think it would be pretty naive of us to think that the only thing are these set of DNA alterations. We haven't looked at the RNA. We haven't looked at methylation. We haven't really fully tried to understand why is the hazard ratio in the HRR negative 0.76? Why is there a signal there? So I would encourage that as a field, we try to better understand that. We're sitting on a lot of data across these studies, a lot of genomic data that could be interrogated to better define what that signal may be.
So we all agree that BRCA patients do best, right? Lowest hazard ratio. I don't think we don't even need to discuss it. In the HRR positive non-BRCA, and that line is all HRR positive, including BRCA, I think, but in the HRR positive, do any of you treat based on specific mutation? We kind of got into it with the CDK, I think, but do you drill down and say, well, this is ATM, I'm not going to use it, and this is, I see you shaking your head, Rana, why don't you?
Yeah, I mean, we do. I think it matters. I think the data is most robust for the BRCA1/2 patients, probably the PALB2, that they're not very common. I think the data has been pretty mixed for ATM. I know the CDK12 data looked a little bit more promising in TALA-PRO2, but it was not as compelling in other studies. So I do think the mutation matters, especially when you're thinking about there's an opportunity cost, because if I'm doing this, I'm not doing something else.
Yeah.
Like I'm not giving them docetaxel that has demonstrated an OS benefit. So you got to think about that.
Before I get to Petros' question, do you think the label should be that specific?
Around the mutation? So,
Should they include ATM?
you know, I think now we're kind of getting into the weeds, because if I'm going to put my
Let's get there. Let's go.
if I put
We're
my
ready.
RCC hat on,
Please.
and we dice up the data in RCC, we would not have doublets for favorable risk. if we're doing what we're doing to these studies,
I
like
really
what we,
know how to hurt a guy. I mean,
you know, if we're doing to these studies,
it's a prostate
like what
session,
we
right?
would have done in our, like if we apply this methodology to all the RCC frontline trials,
no, it's different, right? This is a tumor-directed biomarker with tumor-directed
I
treatment,
hear
right? Those
you,
are
but
stromal,
we're like getting into the weeds of subset analyses, and the trials weren't intended to do that, and that's.
they weren't, but FDA's granted approval just to a subset based on. We're going to talk about that. I know we're running out of time. Petros.
Great discussion. Very quick question regarding, Neeraj, I asked you this on Tumor Board Tuesday. Does the loss of other allele matter? When we get a genomic platform assay report, we just say BRCA period. The community oncologists or even academic oncologists, we have trouble reading these reports. Do we need to push those vendors, commercial and academic, to comment? Is that a loss of heterozygosity? And the second question is, does the presence of symptoms matter in the treatment intensification, combo versus sequence? Great panel.
Go ahead.
I'm glad you asked about the symptoms, because when Rana was talking about docetaxel chemotherapy, which remains a choice in these patients, what to do with those patients who have slowly rising PSA level, they are completely asymptomatic, I cannot justify, as you said, then what I have. So if a patient has, say, PALB2 mutation or CHEK2 mutation, and I know we have, none of these trials were powered to look for rPFS or OS benefit in all those individual small cohorts. I think it's perfectly fine to use an oral pill, which is much better tolerated than chemotherapy, at least based on what most patients wish in those patients who have slowly rising PSA level. So I think it's absolutely fine to not use docetaxel in those patients and go with a PARP inhibitor, which may not have as robust data as we see in BRCA1, BRCA2, but have some data. Coming back to the biallelic loss, I will not exclude anyone from treatment with a PARP inhibitor if they do not have biallelic loss. So that's my stand on that question right now. Yes, it does matter because it predicts better benefit, as you know, better than me, but this is my take. The biallelic loss predicts better benefit, but I'm not going to not treat my patients with a PARP inhibitor if they do not have biallelic loss.
Anybody disagree with that or have a different opinion? Yeah, agreed. All right, we're over time, but we have just a couple slides left. So as you know, there was an ODAC in April around the PROpel study. This is the reminder of what the PROpel study. There's a comment from Heine Weinstock, who is the lead reviewer on this. I'll let you read it, but it's really about that it would be inappropriate today giving emerging data. And Rini, I think this gets to your moving goalpost comments, is that I don't know that the timeline. This study was designed obviously many years prior, and now that it has changed, and now there's emerging data about BRCA mutations, which wasn't known. And in study 8, which was a small randomized study which preceded this, it didn't appear that mutation mattered. Now it was a really small study, et cetera, with all the limitations. So
it's a niggling point, but I would just point out that Dr. Weinstock criticism was not about rPFS in the end.
No.
Although we argue about rPFS and OS.
it was one of the questions to ODAC, is there rPFS benefit, right? It's not in this quote, but it wasn't a main point. That wasn't the main point. I think they were questioning rPFS, I think, of a 5-month difference, and is that meaningful was sort of part of it, but it wasn't the main thing.
Yeah.
Let me just go to I think this is the last slide, and you could read the sort of main issues. And I think this graphic on the bottom was really the whole focus of that ODAC, right? There was the 11% of patients who had BRCA mutations, again, either ctDNA or tumor tissue, clear benefit, no question about it, we all agree. There was that 54% to the right, where there was marginal rPFS benefit, a hazard ratio over 1, which they said about 67 times during the ODAC meeting. And we'll get back to that in the next session. And then this sort of indeterminate, right? And this was what really sank their ship, is this indeterminate. And because it was retrospective and a lot of patients didn't have tissue, as we talked about, et cetera, all those methodologic issues, those sort of real world issues. So thoughts about the FDA stance to say, we're going to take this 85 patient subset and base a label on it. Fair or not fair, Rana McKay? This is being recorded too.
Yeah,
So, yeah.
I think again, it's like you're moving the goalpost. I mean, I think in hindsight, the tissue testing should have been done upfront, prospectively, like the other studies, because I do think that the missingness is a problem in the context of this study. This isn't. And,
But
you know,
you saw from the previous slide, Hannah said, well, we would be rewarding poor trial design if we just gave it a broad label, right? That was the word. It was pretty strong words, like we're rewarding really bad trial design.
But
we should be targeting to the patients who benefit most, right? That's what we're supposed to do.
But wasn't that trial design approved by the FDA to begin with?
You know, I don't
I'm
know
just-
that designs are
yeah.
approved or disapproved. Sponsors
Yeah.
in the room can comment, right? I mean, they have end of phase 2 meetings and all this stuff, right? And it's, again, it's sort of like you get to ask questions and then there's these crafted answers, right? It's this little song and dance, right? It's not like, oh yeah, this is approved and if it's positive, we'll definitely approve your drug. That does not happen, right? That never comes out of FDA, so.
But in principle.
And I would say,
yeah.
good trial design, it's a responsibility of us and the sponsors to do. It's not, you can't say, how come the FDA didn't kill a deliberately bad trial design, right? Like, you can't say, like, my misbehavior. You know, it's like, I don't know that that's really an excuse. I'm not saying that it's a bad trial design, by the way. I'm just saying that to say that didn't they say it was okay doesn't mean that it was good. It just means that it went through.
That it means it may warrant a better oversight early on without wasting so much time and resources of the patients.
Sort of
Their-
Better
their
oversight by
families.
whom?
law and order
Yes.
point of view, I can't do right unless unless someone tells me what the right thing to do is.
We're getting really philosophical here.
yeah.
Tanya, any thoughts on this? I mean, we can go down this rabbit hole all day, right? And it's super interesting. And if you actually haven't seen the ODAC, they're all publicly available. You can watch them. You can go back and watch them. It's interesting.
I mean, I think we criticize subset analysis all the time when we look at a positive trial and then look at the subsets and try to use that to decide who to treat and who not to treat.
Right.
You have to look at what's the harm, you know, what are the toxicities, and you know, when do you leave room for clinicians to do shared informed decision making due to the result of an overall positive trial and versus the label using the subset analysis. I think many of us would prefer to have it in the hands of the treating physicians.
Yeah.
I will say there's confusion as well because I think the label for combo for olaparib is much more restrictive than the monotherapy label with a broader gene set. So there's
Right.
these data create a lot of confusion because in combination it's only approved for BRCA1/2. There's a clear signal in the non-BRCA HRR from this data, and the
Well-
labels are confusing.
I agree the labels are confusing. I think FDA's point was that this undetermined could have included BRCA patients. You just don't know. So perhaps that was driving that. When you say clear benefit, I don't think there was uniform consensus on that middle
No.
box there.
I
Oh,
think
no,
there
not
are
that group, but the
concern-
HRR, non-BRCA HRR. That's what I
Yes,
meant to say.
right.
Yeah.
I think their other concern was that hazard ratio of 1.06
100%.
in that other group. But I would say that this is a really non-pragmatic analysis in that most patients are not getting both tissue
Right.
and ctDNA. This doesn't really reflect common practice, and but it was that 1.06. And you know, it is hard to say that you won't believe subset analyses in some circumstances, and you will believe them in others. And in this case, we're going to believe it out of favor of the drug. You know, that is a tough pill to swallow.
And there's data in ovarian cancer with PARP inhibitors, but also at hazard ratio over 1. Right, and I don't know that data well, but it came out during the meeting, and so there was some, I don't want to call it precedent, but there was at least some example where there was concern. So, all right, we're way over time here. Thank you for that. That was a great session. Appreciate it. A lot to talk about there.